Good morning, everyone. First of all, at the onset, let me thank the Allied team for this kind invitation. So we start with a small video.
And I, of course, was behind the surgeon's right shoulder. And when he put his hand into the left side and he said, I can feel a tumor, I could feel the blood go up into my head and I couldn't stand still. I moved around that operating room and I knew that this wasn't going to be the only case of this kind.
So this is Jerome Cohn, who first described the Cohn syndrome. He first in 1955 when he described it in a 34-year-old female who presented with metabolic alkalosis, hypokalemia and periodic paralysis-like syndrome. He was very happy because that was the first time he was standing behind the surgeon, and when the surgeon said that there is something in the adrenals, something protruding from the adrenals, he was very happy. And that is how the Cohn syndrome came into existence. So we are going to deal today with a hypertension case. The case scenario is like this 62-year-old female who presented with a BP of 170/100 on telmisartan 80 mg, amlodipine 5 mg, metoprolol 50 mg, and clonidine 100 mg PD. With the routine investigations like hemoglobin 12.4, TSH was normal, urine albumin was negative, and creatinine was also within normal limits. Potassium was on the lower side of 3.3. And in the mind, a possibility of probably hyperaldosteronism was considered, and the ultrasound abdomen also showed a suspicious nodule in the left adrenal gland, and the patient was taken up for a CT abdomen, which showed a 2.1 centimeter nodule. So how do we proceed with this case, and what are the other things that we take into consideration when you consider a patient, a 62-year-old female with hypertension? So is this a refractory hypertension, resistant hypertension? So resistant hypertension is when, as per the ACC or the AHA guidelines, when the patient should be at least on 3 medications with 3 different mechanisms of action, with at least one being a thiazide diuretic. And resistant hypertension is also considered when there is a BP is controlled even on 4 drugs. And refractory hypertension is when you have 5 drugs and the patient is still not controlled, BP is not still controlled, and out of the 5 drugs, one should be an MRA and the second one should be a thiazide. So that is refractory hypertension. And when you basically consider the difference between resistant and refractory hypertension, the prevalence, of course, refractory hypertension is in the range of 5%. It is more common in the older age because of the arteriosclerosis also coming into play. And the aldosterone levels are normal usually in the refractory hypertension group, whereas in the resistant hypertension it is very high. And another mechanism is mostly sympathetic overactivity is considered to be one of the crux in case of refractory hypertension. So this is basically the difference between refractory and resistant hypertension. When you go about a patient with resistant hypertension, first you have to look at the BP, whether it is the BP has been recorded correctly, confirm with multiple recordings. If you have in doubt, go for ambulatory blood pressure measurement. Review and assess the medication adherence, see that the patient is not taking any other medications, excessive salt intake, any other NSAIDs, reinforce the lifestyle and look for advise him to take physical activity regularly and limit the alcohol use. If this all is taken care, then only you say that the patient is in resistant hypertension. And you have to consider evaluation for obstructive sleep apnea because of the obesity pandemic that is coming up. And one of the last thing is to exclude secondary hypertension. So secondary hypertension obviously have many causes, out of which most common causes are renal disease, parenchymal disease, as well as the renovascular hypertensions. And second, among the endocrine causes, the most common, maybe after the thyroid diseases, would be primary hyperaldosteronism. What makes it different is that the secondary hypertension, if not treated properly, and that too at the early ages, this can cause more of comorbidities, and cardiovascular risk is also more in case of secondary hypertension. So they have to be caught young. This was one of the articles that came up in JACC, which shows cardiac phenotypes in secondary hypertension. Each type of secondary hypertension has specific phenotypes, and if you take primary aldosteronism, the left ventricular hypertrophy is more, and the diastolic function is also affected in patients with primary aldosteronism. The strain or the LV systolic function, if you assess by strain, is also reduced. And in CMR, if you do a cardiac magnetic resonance imaging, the LVH, fibrosis and edema stands out in case of primary aldosteronism. And the cardiac events like AF are also more in case of patients with primary aldosteronism. So primary hyperaldosteronism is a heterogeneous group of familial and sporadic disorders. It is characterized relatively by autonomous, that is renin-independent aldosterone production. And the triad that Cohn described first, the Jerome Cohn first described, was hypertension, hypokalemia and metabolic alkalosis. But the point to be noted is that hypokalemia may be noted or seen in only around, say, 30 to 40%, and some say only around 50% of patients may only show hypokalemia. So you can have normokalemia also in cases of primary hyperaldosteronism. So it will be why we should screen, when we should screen, who should be screened, and how we should be screened. As I said, the detrimental effects are independent of the BP and angiotensin II levels in hyperaldosteronism, and it's simply dependent on the concomitant sodium intake. The pathological cascade, if you know, it starts from the reactive oxygen species, vascular inflammation, fibroblast and myofibroblast proliferation, collagen production is increased, and then it leads to perivascular fibrosis and interstitial fibrosis. So that is the basic pathology that you note. So these are all images showing, the CMR images showing LVH, fibrosis and late gadolinium enhancement, and the strain images showing a decreased systolic pattern. When is screening recommended? Adults with hypertension less than 40 years. All adults with hypertension less than 40 years. Hypertension with spontaneous or thiazide-induced hypokalemia. Resistant hypertension and hypertension with adrenal incidentallomas. These patients should be screened. So screening is with the aldosterone-renin ratio. Then case detection is by that. And once you detect that, case confirmation with maybe with oral sodium challenge test or the saline infusion test, but that's rarely done. And then you go for the subtype evaluation, where it is a subtype evaluation is whether it is a primary adenoma-like thing or it is an adrenal hyperplasia. If it is adrenal hyperplasia, it is usually bilateral. Sometimes rarely it can be unilateral also. The most common is the adenomas, which increases with age. So if you have a 70-year-old or a 60-year-old male, the chances of being it in adenoma is more, and it can be unilateral, and rarely that can also be bilateral. That is where you need the specific investigation of the gold standard investigation of adrenal venous sampling. So if you go for the first screening test, it is the aldosterone-renin ratio that is widely available and is used as the screening test. But recent guidelines have said, along with the aldosterone-renin ratio, the renin activity is what we do in renin ratio. Other than that, you can directly calculate the renin levels also. So that is the DRC, or the direct renin calculation. The other one is the plasma renin activity levels, that is a PRA. But the problem here is that these patients are usually on multiple drugs, as we have seen. And if you do a test, the arginine or the aldosterone-renin ratio in these sorts of patients, lot of drugs can interfere with that. But the current recommendations is that you need not stop the drugs, you can do, and if the probability of the patient having a primary hyperaldosteronism is high, and if the results are not concomitant with that, you can try to stop the interfering drugs and then repeat the test. So first recommendation is to do the test on drugs. Case confirmation is usually not done, but is not widely available. These are the tests that can be used for the case confirmation. And for the subtype evaluation, you do the adrenal vein sampling, usually done by an interventional radiologist. It's technically expertise is needed, not done in all centers. So that is also not done. Then what can we do is an CT, which can prove whether it is an adrenal, but smaller lesions can be missed. So has to be a high resolution CT, and this can rule out adrenal other pathologies like an adrenal carcinoma or other tumors. So if the probability of lateralizing the primary aldosteronism, lateralizing means only one side is producing. So if you do an adrenal venous sampling, that sample will alone show the high levels of aldosterone. So that is called. So when the probability is low, you directly go for the treatment, that is the melanocorticoid receptor antagonist like aldosterone 25 mg. You start and then titrate it according to the renin levels. If the probability is intermediate, you go for, as mentioned, the aldosterone suppression test. And if the probability is high of a lateralizing primary hyperaldosteronism, you go for a CT. And if the CT is showing bilateral aldosterone production, you go for MRA. And if it is lateralized or is a single one, you go for adrenalectomy or removal of the adrenals. So these are the criteria for adrenal venous sampling. So adrenal venous sampling is not a mandatory, but it can be taken as a selective approach, taking into the consideration whether the patient will go in for a surgery or he opts for a medical management. So as simple, if it is bilateral disease, go for medical management, and if it is a single side disease, you go for surgical. The thing to be noted is that as per the ESC guidelines, the current guidelines, even it is a class 2 recommendation for screening all patients regardless of age for primary hyperaldosteronism. So the take home messages would be higher prevalence of structural and functional heart damages have been noted in primary hyperaldosteronism, and is one of the most common causes for secondary hypertension. It is underdiagnosed but potentially curable with the current treatment. Universal aldosterone renin ratio screening is gaining support, but the adrenal venous sampling remains the gold standard, and imaging guided treatment is also currently emerging. Thank you very much.
Praveen, despite the array of investigations, practically the management boils down to the use of MRAs. And in the resistant hypertension, the PATH study, I think it is the PATH study, resistant hypertension, where aldosterone antagonist was found to be the most useful additional drug which can control the resistant hypertension. So when do you really suspect? In the practical, because all are seeing hypertension, all of us sitting here are seeing hypertension day in and day out. So is it a patient on ARB or ACE inhibitor who have a low potassium level, despite a drug that can increase the potassium level? If they have a low potassium, but as you said, potassium is not a strict criteria now. It's only 30 to 35% of the patients, and it's coming up that is plasma aldosterone renin ratio has to be done for every patient, especially a young patient. That I think is the most important practical thing. Anybody with hypertension less than 40 years, this must be included in the preliminary investigations. How often do you see hyperaldosteronism? Because you are seeing large number of patients.
The problem is that though the guidelines recommend, practically these tests are not available at our center, and this has to be sent out. So the number of screening tests that we are doing is very less. Maybe if we increase the screening, we will pick up more cases. Once the patient is really resistant, only we go for the investigations like from the baseline. So otherwise, when you do a routine evaluation for a patient with hypertension when he comes first time, we do only the routine investigations like the blood or the albumin, the serum electrolytes do come into that. But beyond that, the aldosterone renin ratio, we don't do. That is the problem. But the current recommendations, taking into our practical difficulties, have to be taken in consideration. But they say that we have to screen all patients for aldosterone ratio. And in the incidence is around 10% in resistant hypertension. But we have certain studies are showing up to 30% also the incidence.
So all difficult to control hypertension should go for this thing. All hypertension with a low
when
potassium,
you have a baseline hypokalemia.
Potassium should go for this
and
thing.
That too on a, just as you said, on a melanocorticoid receptor antagonist. If the patient is still having hypokalemia, then you have to.
So the plasma aldosterone direct renin activity, that is one you are telling, the direct renin activity, and a CT scan abdomen. I think that can give an answer in majority of the patient. And the treatment is predominantly mineralocorticoid receptor antagonists, except an unilateral disease.
Yeah, yes.
Unilateral disease where surgery is a total cure. Total cure. Thank you. Fantastic talk. Give him a big hand.